Um, all right. Welcome and good morning, good afternoon, everybody. Welcome to our webinar. My name is Betty Kappa. I'm the president of the French American Business Council of West Florida. And I am very excited about this webinar because we are going to talk about the cancer in 2024. Novel paradigm in prevention and treatment. And we are honored to have as speakers Professor Christian Brechot, who is with us, MD, PhD, Department of Internal Medicine, University of South Florida. Thank you, Christian. And Gregoire Bergier, MD, Medical Oncologist and Hematologist, Florida Cancer Specialist. So thank you for being here. And it's very important right now in 2024, and especially this month in October. Um, it's a cancer awareness. So thank you for being here. Before we start, we will have, if you have any questions, put your question in the chat, and at the end of the presentation, we will have the questions because Charles, who is with us, Charles Touvenot, who is on my board, will assist the technical, all the questions you will have, he will ask everybody. So we will start now with a little infomercial because we have in our member, we have proud to have Deuxième Avis.fr, who is a company in France and who can assist people who have different pathologies and want to have another advice from another doctor. So we will ask Estelle to present. She has a 2-minute presentation about Deuxième Avis. Estelle?
Yes. Je vais partager mon... Est-ce que vous le voyez?
Non, pas encore.
Non? C'est bizarre.
Je put her, oh, it's coming.
Okay. Okay.
Here we go.
So, sorry.
Non, il faut que tu mettes ton diaporama, Estelle, pour la présentation, parce que là, on voit ton pitch, non?
Oui. Excusez-moi, sorry.
En haut à droite, tu as diaporama.
Ah oui. I'm sorry.
I just wanted to say again, guys, don't hesitate to ask questions about Deuxième Avis or when Christian Brechot and Grégoire Bergier talk, guys. Don't hesitate to ask questions. We'll come back to them at the end, the Q&A session.
Yes. Hello, everyone. My name is Estelle Huynh. I'm the partnership assistant of Deuxième Avis, and I'm here today to introduce our service, deuxièmeavis.fr. So the healthcare system can be very expensive and very different from depending on where you live, and sometimes it's kind of hard to know exactly if you are getting the best treatment or the best advice. So making medical decisions can be really tough, especially when you are like living abroad. So that's where deuxièmeavis.fr comes in. It's an online platform that can give you access to medical specialists in France, offering you a second medical opinion. And it's a very fast and very simple process. Like all you have to do is sign up on our website and select your illness. And then you have to upload your medical records online. Everything is secure and confidential, so you don't have to worry about it. You can always call our patient service if you are having trouble doing it online. Our patient service is here to help you and guide you through every step of it if you need. And everything is done in French, but if you like, we also have an English version, so it's really up to you. Like I said earlier, the medical care can be very expensive and unpredictable. So, deuxièmeavis.fr makes everything clear from the start. There are no hidden fees or additional charges. Prices are already fixed. So it would be 500 euros. Therefore, people can actually have access to medical care is easier.
Thank you. Thank you, Esther. And then if you want to have, if you have questions, just put your question on the chat. And you can also you will have on our website, franco.org pretty soon. Will be online next week. So you will have the contact also for Deuxième Avis. Well, thank you, Esther. Now, I would like to introduce Professor Christian Brechot. He holds MD and PhD degrees. Beginning in 1981, he studied molecular biology, and cellular biology at the laboratory of Pierre Thiollet at the Pasteur Institute and at the Necker School of Medicine. He obtained his PhD in biochemistry from the University of Paris 7 in 1985. In 1989, he became full professor of cell biology and hepatology at Paris Descartes University. And in 1997, he was appointed head of the clinical department of liver disease at the Necker Enfants Malades Hospital. From 2001 to 2007, Christian Brechot was general director of INSERM, the French National Agency for Biomedical Research. In 2008, he was appointed as Vice President of Medical and Scientific Affairs of the Institut Mérieux Company. And from October 2013 till September 2017, Dr. Brechot served as President of the Institut Pasteur. He is now, since 2018, a full professor with tenure at the University of South Florida in Tampa. In addition, from 2017 to 2023, he has been acting as president of the Global Virus Network, a network of 70 research centers worldwide, coordinated in Baltimore and in Tampa. He is now serving as vice chair of the board and emeritus president. So please help me welcome Professor Christian Brechot.
Thank you. Thank you so much, Betty. Thank you for the invitation and thank you for the introduction. It has always been a pleasure to work now as a board of FRAMCO with you and with the other friends. I'm going to share my slides. So let me check that everything is working. Can you see it?
Yes.
Okay, I would just want to. Okay, so I will make a rapid presentation. Of course, we can come back to this during the questions and answers sections on the epidemiology of cancer in 2024 and how we can foresee in the future these evolutions. And Gregoire Bergier will really speak about the treatments and then we will have the overall conversation. So my disclosures. And so the first point is that we know this, but this is very striking. I mean, cancer is really the major public health threat. On the left, 20 million present in 2022. Now we foresee 32.6 million in 2045. Of course, it's always difficult to be sure of the numbers, but what it means is that this is really part of our life, and that without getting into detail, many of those people who are aging will get cancer. And this is really something which is well exemplified with this slide. Cancer is a disease associated to aging. This is the evolution with age of the incidence. You would have the same with the prevalence of cancer, and you can see the very, very important increase in the incidence. And I will come back to this, but you can also note this part for younger people. I will come back to this. This is for males. Exactly the same holds true for women, for females. So this is really a general phenomena worldwide. So these, I would say, are relatively bad news. Now, the good news, and Gregoire Bergier will come back to this, is that when you look over the past few years, it is clear that the overall cancer mortality has been significantly reduced. And this is due to the progress for early diagnostics, for prevention of risk, and of course, for treatment. Now, again, I don't want to go into detail, but we all know that the distribution of cancer will differ between men and women. So men, you have the lung, which is leading, you have the liver, this is worldwide. You have the colorectal cancer, the stomach cancer, the prostate cancer, of course, and then you have less frequent cancers. For women, you have, of course, the breast cancer, the lung cancer, the colorectal, the cancer of the cervix, to less extent the liver, stomach, and others. So clearly, and this makes a lot of sense, of course, we do have a different distribution for men and for women, but we have in common this increase in incidence with aging. Now, very concerning is the recent increase in cancer in younger patients. What I mean is under 40. Of course, this is arbitrary. Now, it's always difficult to quantify because one can advocate that we have better diagnostic procedures, that younger people would care more about being screened. But yet, at the end of the day, there is an increase in incidence in younger patients. Thyroid cancers, breast cancers, colorectal cancer, for example, in Florida, several papers, articles in newspapers have pointed out the increase on colorectal cancer, some sarcomas, and others. So it's really a matter of concern. Now it really reflects, and this is, of course, a key point, the importance of knowing the risk factors for cancer. Well, let's be clear. We don't know all of them. There are so many things that we still need to understand. We know that there are some inherited genetic mutations for breast, ovarian cancers, colorectal cancers. However, regarding the overall population of patients with cancer, they only represent a minority fraction. We know that obesity and diabetes are important risk factors for cancer. The percentage of increase varies from, of course, one cancer to the others. So we enhance the wide range between 5 to 40%. Most generally, we speak about colorectal, breast, but others, and actually all, most if not all of the human cancers have an increased risk due to obesity and diabetes. Smoking, of course, lung cancer, oropharyngeal cancers, but others. And again, smoking is involved in most, if not all, of the cancer, but to a lesser extent for some of them. Alcohol, again, of course, mostly for liver, pancreas, but also breast and other cancers. Chemical carcinogens, pollutants. All cancers We don't know exactly to which extent. This is a major point for the future. And how can we really better understand what's going on? And this may have a huge impact for the future again. Food, diet, sedentary lifestyle. This is, of course, connected to obesity and diabetes. Very important. Infectious agents, about 15 to 20% of cancers worldwide. And I will show a slide in 1 minute. So we do identify a number of risk factors, although we have still so much to learn. Overall, it's about the impact of environment in general terms, food and diet, but also climate change, pollution, chemicals, infectious agents, which really impact on the interplay between our genetic and these huge populations of bacteria that we call microbiome, that we have in the gut, in the skin, in the urogenital and the vaginal area. And that's really how these risk factors are really working. Now, 2 examples before concluding. Risk factor for cancer, infectious agents. This is sometimes underestimated. Bacteria, Helicobacter pylori for gastric cancer, human papillomavirus for cervical cancer, head and neck, and also increasingly penis cancers, hepatitis B, hepatitis C virus and liver cancer, and HTLV1, Epstein-Barr on different forms of lymphomas and leukemias and others. Now, very interesting for hepatitis B and for human papillomavirus, we have a preventive vaccine, efficient, safe, which should really suppress the risk for our teenagers and young people. Risk factors for obesity, breast cancers, corpus uteri, colon cancer, and others, kidney in particular. So it's a significant risk factor, and unfortunately, we all know how prevalent now obesity is, not only in the US, but also in Europe and actually in all countries. So to conclude my last slide, what are the major challenges for cancer? Well, prevention. We need to pay more attention to prevention, which means knowing the risk factor, but which will also mean to avoid the risk factors. Early diagnostics. This is critical. Many novel tests are being proposed based on molecular biology, on imaging, on others. It makes obvious sense that if you get an early diagnostic, you will be more efficient. And finally, the new treatments, and Gregoire Bergier is going to address these points. So in summary, this is a painting from Magritte. What we are painting the bird, but we are still looking at the egg. And it's everything on the translation between the egg and the bird. Cancer is a major threat for all populations, including in Africa, in Asia, not only in the US and in Europe. A lot of progress has been made. Gregoire is going to address this, but still, we need to pay a lot of attention to this. And again, I thank Franco for organizing this webinar. Thank you so much. I will stop there.
Well, thank you so much, Christian. That was really like eye-opening, I hope, for everybody. And I love the painting, the last one. It is eye-opening. Thank you. So if you have any question, please put in the chat box so we can ask Christian afterwards questions. So now we're going to see with Gregoire Bergier, he's an MD. And Dr. Gregoire Bergier was drawn to oncology because of the exciting scientific discoveries that are providing a better understanding of cancer. So he values the special relationship he is able to develop with his patients and finds fulfillment in the availability of new therapies, such as immunotherapy, to treat many forms of cancer so effectively. So Dr. Bergier attended medical school at the University of Lausanne. in Switzerland and completed his internal medicine internship at the Hospital de Bellevue in Yverdon, Switzerland. He completed his residency in internal medicine at the University of South Florida in Tampa and fellowships in medical oncology and hematology at the University of South Florida, H. Lee Moffitt Cancer Center and Research Institute in Tampa. He is board certified in medical oncology. So prior to joining Florida Cancer Specialists in 2011, Dr. Bergier provided oncology care to patients in Tampa and St. Petersburg. So an additional, Dr. Bergier speaks English, French, German, and Spanish. That's why I got from doctor. Is that correct, doctor?
Yes.
Thank you.
Thank you.
Okay, welcome. And
Thank
he's going to
you.
share his slides.
Thank you, Betty. Can you hear me?
Yeah.
Yes,
All right,
perfect.
good. So let me share the slides. All right. You got it?
Yes,
Yeah.
perfect.
All right. So what I thought I would do today is give a little bit of a historical overview of, of cancer and treatments, and then kind of where we are today. Um, that's the next slide. Here you go. All right. So the earliest description of a tumor that we know of dates back to 1600 BC in what's called the Edwin Smith Papyrus, which are ancient documents from Egypt. Around 400 BC, we all heard of Hippocrates, who used the term carcinos or carcinus in Latin, meaning crab. So that's where the association between crab and cancer comes from. And he believed that too much black bile and humoral imbalances in the body were the cause of cancer. Then we get to the Middle Ages and Renaissance, where in 1775, a surgeon from England, Percival Pott, discovered that chimney sweeps were more likely to develop a cancer of the scrotum, which he linked to exposure to soot. And that was really the first time that there was this link that Christian was talking about between environmental factors and cancer. Then another British surgeon, a Scottish surgeon from in the 18th century, John Hunter, suggested that cancer might be cured by surgery. And so that's really the first time that we talk about treating cancer. And it took about a century before we actually really came into cancer treatment with surgery, thanks to anesthesia. So in the 1800s, there was more theoretical discoveries on cancer. In 1838, Johannes Mueller showed that cancer was made up of cells and not lymph. And that was the birth of pathological histology. And then in 1860, Carl Thiersch proved that cancer was spreading through malignant cells. So you see the kind of the development of understanding of cancer that has ultimately led to the current treatments that we have. So this is a pivotal time in 1894 where William Halsted did the first mastectomy for breast cancer. And that is still the current procedure that is done in our breast cancer patient. other breakthroughs with another topic that Christian touched on, with infectious causes being associated with cancer. That was the first description by Francis Peyton Roos in 1911 about a virus causing cancer in chicken. Then came in the 20th century the microscope and the ability to delve deeper into the specifics of cancer. And then in 1953, a breakthrough discovery with the DNA helix by Watson and Crick, which has led to the modern understanding that cancer is really a disease of DNA, and that DNA mutations lead to loss of control of the proliferation of cells. And a lot of what we do now is based on these discoveries. In parallel to surgery, there was the discovery of X-rays in 1895 by William Röntgen, and then the discovery of radium by Marie Curie in 1898, leading to the use of radiation to target tumor. So these are two techniques of treating cancer. We have surgery, we have radiation. And then came the 1940s with World War II, where there were developments of the mustard gas derivatives. And that was then found to be effective in treating certain cancers, initially lymphomas and leukemias. And that was really the birth of the chemotherapy that we use now. So we see that understanding of cancer as a systemic disease and the transition from focused local treatment to systemic disease management and the recognition of metastasis and spread of cancer cells is now what we are targeting with our treatments. In the 1950s was the development of hormonal therapy, which is very effective in treatment of breast cancer and prostate cancer, which are still used currently. And then in 1971, there was President Nixon's declaration on the war on cancer, and that led to a huge increase in funding and establishment of cancer research centers that has led to breakthrough from cancer biology to drug development. Then that is more kind of what I lived through. I'm 55 now, and this really happened while I was in residency and fellowship here, 1980s to 2000. There was the emergence of precision medicine and targeted therapies with such discoveries of molecular targets like HER2 in breast cancer, CD20 in lymphomas, and then the development of drugs targeting these molecules like Rituxan that was approved in 1997, first monoclonal antibody to be approved, and then Herceptin in 1998. As well as Gleevec, which are called small molecules or tyrosine kinase inhibitors that are targeting a certain molecular abnormality on cancer cells in CML. And this was all treatment based on those genetic mutations of tumors. Let's see. That's just to touch on the origins of immunotherapy that has been a topic for decades and even centuries, with William Bradley Cooley in 1891, who tried to treat a bone cancer using a mixture of live and inactive bacteria. Unfortunately, for many years, immunotherapy has not worked well. We were unsuccessful. There were a few breakthroughs with interferon and interleukin-2, also BCG that has and still is used in treatment of superficial bladder cancer. But for the most part, we tried vaccines for cancer, and they were relatively ineffective. And so this is until recently, when thanks to the improved understanding of the role of the immune system in controlling cancer, there was the discovery of a switch in the immune system that we call off switch, with several proteins that are part of that switch, one called CTLA4, one called PDL1. And then the invention of creating antibodies against those proteins. The first one was ipilimumab, or Yervoy, that is targeting CTLA4 and is used extensively in metastatic melanoma, and now earlier stage melanomas, and now also other cancers. And that was soon to be followed by PDL1 antibodies that are now quite ubiquitous in the treatment of cancers, that was approved in 2014. So it's been about 10 to 15 years that we are now using these drugs, with incredible improvement in survival and sometimes even cure of cancers that used to be totally incurable, stage 4 metastatic. And so I just put the list of the cancers where we use these drugs, and you can see how exhaustive it is. Melanomas, non-small cell lung cancers, small cell lung cancers, liver cancers, Hodgkin's lymphoma, head and neck cancers, triple negative breast cancer, bladder cancer, kidney cancer, esophageal cancer, cervical cancer, colon cancer, skin cancers, and stomach cancer. So very, very extensive use of these immunotherapies. As an example, I think the most striking is in metastatic melanoma, which was one of the first cancers where we used those drugs, where you look at a median survival that used to be between 6 and 9 months and is now, thanks to these new treatments, up to 6 years. And what's even more striking is how about half of those patients with metastatic stage 4 melanoma are long-term survivors, which really mean cure. And I think all of us medical oncologists have patients that have survived metastatic melanoma and now are 5 to 10 years out, even with metastatic disease to the brain, and who are doing well. Another example that's been mentioned a lot is chronic myelogenous leukemia, because Gleevec, which is a pill that you take once a day, has allowed for patients with CML to live almost a normal life, when they used to have average survival around 5 years. They would almost all transform to an acute leukemia and die unless they were able to get allogeneic bone marrow transplant. Now with Gleevec and second and third line tyrosine kinase inhibitors, we're able to give these patients pretty much a normal life, almost normal life expectancy. And even in about half the cases, we can stop those drugs and have patients who are basically cured. So to finish, I wanted to show an example of a patient of mine that I've had recently. I was following this patient for anemia, and I got a phone call from her dermatologist that she had developed a couple masses on her scalp, which you see on the left upper side. This was biopsied, and there was a quite difficult diagnosis. They mentioned the possibility of a melanoma. They mentioned the possibility of a lymphoma. And it takes time to make these diagnoses, because you need to have a lot of special stains and sometimes molecular markers. And so while we were doing that, we did a staging, which I will show here, and I'll come back to the picture. You can see on your left that this is called a PET scan using radioactive glucose And the black spots are basically areas of cancer. You see on the right, the yellow spots on the bottom is a tumor in the lung. And then you see a tumor on the left there in the neck. You see multiple lymph nodes. And so we biopsied the tumor in the lung, and it turned out to be lung cancer, a non-small cell lung cancer. And this was later confirmed that the nodules on her scalp were also non-small cell lung cancer, which is a fairly odd presentation, an atypical presentation. So we had to make a decision how to treat her. And this is now a part of what we do. We do molecular testing. And you see here, we tested for that PDL1, which is part of the off switch, and she has very high expression of PDL1. And so when I saw that, knowing she had non-small cell lung cancer, adenocarcinoma, that she had a high PDL1, I thought, well, we should try and treat her with a combination chemotherapy and immunotherapy. So this is what we did. Initially, we were not able to get the approval for the immunotherapy, so she started chemotherapy alone and actually really didn't respond well. She was getting worse. She was to the point where she came in a wheelchair. She felt she was dying. And so we were able to start then the immunotherapy. And this is just to show you, after 3 months, you could see here, like it's getting a little lighter. You can see it's becoming crusty, almost gone. And on the last picture, completely gone. So we didn't really even need another scan to see that it was working. She was feeling a lot better. She was able to go back home from her rehab. But on the follow-up PET scan, you can see how all the areas on the scan are completely gone. You can also see where the lung cancer is completely gone. And so, interestingly, we later got the result of her, what we do now is next generation sequencing, looking for a number of genetic mutations that may be susceptible to being targeted. And she actually has also what we call a MET exon 14 mutation, which is targetable with a pill. So actually, before starting the immunotherapy, I was so worried that she was about to die that I prescribed that medication. But again, with insurances, it takes time to get things approved and then delivered to the patient. By the time she got that pill, she had started responding to immunotherapy. So we did not need to go with this targeted treatment, but that definitely is also an option for this patient. So I thought it was interesting to show you kind of where we are now in the treatment of cancer. I wanted to touch base a little bit on what's coming. A lot of it has to do with immunotherapy. There are new treatments. Some of them are already approved in certain cancers. Some will be. CAR T therapy is a very promising treatment. It means chimeric antigen receptor T cell treatment, using your own white cells, genetically engineering them out of your body, expanding the population, and then re-injecting it so that it will go and educate your immune system to fight your own cancer. There's other treatments such as TILs or tumor infiltrating lymphocytes, bispecific antibodies. This is kind of a new generation of monoclonal antibodies that are all being developed. There's, in parallel, ways to detect cancers that are becoming more effective. I showed you that result of that MET amplification that was found through a liquid biopsy. So we can look for cancer cells that are floating in the blood and then do the test on that rather than actually needing the tissue. We then do this next generation sequencing that is looking for a lot of different mutations that are potential targets for our treatment. So what are the challenges for the future? Definitely understanding better the mechanism of drug resistance. Unfortunately, despite all our treatments and all our progress, a lot of patients still die from cancer. They still progress after an initial response, and this is a very big area of research right now. And then there's other factors, addressing disparities in access to care. This is a whole other area that needs to be addressed. There's new technologies such as CRISPRs to edit genes, and that is actually the first was approved in the US for treatment of sickle cell anemia. And that is actually changing the gene that is responsible for a disease. Obviously, also the use of AI is starting to be very prevalent in medicine, as well as nanotechnologies. We have to focus on early diagnosis, like Christian was mentioning, using screening also as a key to improve outcomes and shift in public health policies regarding cancer prevention. So we'd both like to encourage you to be proactive in adopting healthy behaviors with lifestyle changes, stop smoking, drink less alcohol, go and exercise, eat less fat and red meats, do your screenings with mammograms, colonoscopies, and scans if you're a smoker, and live a good life and be happy. And that is the end of my presentation. Thank you.
Thank you, Dr. Bergier. Very, very interesting. And well, also eye-opening. There is a lot of treatment going on. So it's very important to find out which one is best for you. So Charles, do we have any question?
We do have a few questions now. One that I'm going to ask right away, and I will come back to the other one because it's a very specific questions. And I think it's going to be for Gregoire because it appeared when Dr. Bergier was speaking. So I assume it's for you. The question is the following: are all types of cancers pathway dependent on CTLA-4, or are different antibodies responsible for each cancer?
So no, CTLA-4 is not related to the cancer. It's related to your immune system. The problem is not all cancers respond to the manipulation of CTLA-4. So unfortunately, many cancers don't respond to immunotherapy. If immunotherapy worked in everyone, that's all we would do, and we would cure cancer. So firstly, a lot of cancers don't respond to this manipulation of the immune system. And then secondly, a lot of times we treat patients with immunotherapy. It works for a while, and then it stops working. So this is, again, it's an area of research. There's some theories that some cancers may be covering themselves with a carbohydrate shell that makes them invisible to the immune system. And so now the goal is to try and render the cancer cells susceptible to the manipulation of the immune system.
Thank you, Gregoire. So I will move on to the next question. Actually, we have three more questions. So the next one is: we often hear about research on mRNA vaccines for certain kinds of cancer. Is that something that's realistic?
Christian, you want to comment?
I think that we can both answer. It's clear that the mRNA vaccines have been a breakthrough, in particular for infectious disease, and of course for COVID-19, because it has saved millions of lives. I would say that so now these companies have extended the use of these mRNA vaccines for some cancer, in particular for melanoma, Gregoire was referring to, and also for lung cancers. it's very debated, to be clear. On the one hand, mRNA vaccines would mostly stimulate what we call humoral immunity. And for cancer, it's more about cellular immunity. However, when you look at the results, they are really interesting, at least in our view. So I would say it's an open question. It's one of the interesting paths to be explored. Nothing for sure at the moment. I don't know, Gregoire, if you would agree on this.
No, I totally agree.
Perfect. Well, thank you both for your answers. I see we have two more questions. What do you think about getting a second opinion in a cancer diagnosis? Is that something that's interesting to do?
That's for Gregoire.
Yeah, never. You get one opinion and that's it. No, no. Of course. I always encourage my patients to get second opinions. I think a couple of things. You have to get a valid, a good second opinion. You know, getting the opinion of another person, it may not be really useful. So I always tell my patients who ask, you know, don't go and get a second opinion with my colleague next door because he does the same as I do. You want to get a second opinion with someone who's more specialized. And so I work a lot with Moffitt Cancer Center. I work a lot with Tampa General that has now with USF a very good cancer center because you get someone who's more specialized. And so that's always the challenge in community oncology that we are generalists. We see all cancers. We also do hematology, including benign hematology. So there are things we just don't know or we don't have time to delve in. And so then, of course, it's very useful to have the guidance of someone who is an academic center. And in other situations, it's very clear how you treat it. If I have a diffuse large cell lymphoma, everyone treats them the same. And so then it's less important. But I never dissuade a patient from getting a second opinion. I always encourage it. I think it can only help. Now, then the question comes, do you need a third opinion and a fourth opinion? You know, I have patients who do that. It becomes a little messy and a little complicated because you can get a lot of different views, and then the patient ends up being a bit lost. They don't know who to listen to, what to do. And the problem is also that, you know, medicine, of course, it's a science, but it's also an art. It's not always that there's a clear answer or only one clear answer to a question. There may be several. And then when you get several answers, then you're not sure which one to take. So, but yes, of course, I think second opinions are very, very important.
Thank you, Gregoire. And actually, I'm going to bounce back because I know we have our friends from Deuxième Avis here who are members who do have specialists who can answer questions as well. So don't hesitate to go check out their website, guys, deuxièmeavis.fr. We have two more questions, actually. Another one just appeared, and I'll come back to the last one, which is a bit more general in the end. Why do triple negative breast cancers do not have receptors?
Well, Gregoire, you may want to answer. Nobody really knows. I mean, you see, what you need to understand is that development of a cancer is due to a number of mutations which will accumulate. And each of these mutations will lead to the selection of the cell. That means will provide a growth advantage of the cells and will also allow them to escape the defense mechanisms of our organisms, including the immune response or other mechanisms. So why do some subsets of cancer develop being triple negative? Because they accumulate some mutations which lead to absence of expression of the receptor in the tumor cells. Now, why some patients will develop this and others will not, we don't know. We do not really know. We know the results of it. So it's not a good answer, but it's a status of knowledge.
It is the answer you have. Thank you. And I'm going to move on to the last question. I just need to find it again. So, what are the best clinics in the Tampa Bay area for cancer treatment? And is there really a difference in their services?
Well, the one where Gregoire Bergier is working.
Yeah, I confer. Yes, I concur.
It's very difficult to answer. I think that I don't know
You know,
what.
that's really there's a number of clinics. So the bigger difference is you have community oncology that are, private practices that are close to where you live. And then there's academic centers. And Moffitt is an academic center, and Tampa General USF is an academic center. And so some people just prefer to be an academic center because they feel they have a guarantee that they have a certain quality of care. And some people, they want to be close to home. Um, you know, with our aging population here in the Tampa Bay area, you see, or in Florida in general, it is difficult. I work in the Palm Harbor, so Pinellas area. My patients in their 80s, they hate to go to Moffitt because it's like an hour and a half. It's in traffic. They don't want to drive. It's super stressful. And so we provide them quality care close to home. It doesn't mean they don't have access to Moffitt. I have many patients. For example, we treat a lot of multiple myeloma patients. Multiple myeloma has become quite complicated. There's been about 20 different drugs that were approved in the past 10 years. There's multiple levels of treatment. Often you need a bone marrow transplant. We do not do bone marrow transplant in private practice. So I refer almost all my patients to Moffitt for an opinion. I know the guys there. I have their cell phones. We communicate. But when they need a treatment, these treatments are often twice a week. They don't want to drive to Moffitt twice a week to get their treatment. They don't want to go there an extra time to get labs. So we have to learn how to collaborate. There's other situations where I really feel there's no benefit of going to Moffitt. It just depends, but obviously, I can't vouch for every practice in the Tampa Bay area. There are certainly some that are not good, but Moffitt is great. Tampa General USF is great. I think Florida Cancer Specialist is great. We provide clinical trials. We do research. We all the guys here, we all trained at Moffitt. Some of us were assistant professor there for a few years. So I think you have at least here in the Tampa Bay area, you have a lot of options. This may not be true in more rural areas where you just don't have those options.
Well, thank you very much, Gregoire, for your answer. I don't see any more questions, guys, so I think we're done. Betty, do you want to add a last?
Yeah, thank you. Thank you, Professor Brechot. Thank you, Dr. Bergier. A lot of great information. And if there's a lot of information, if you want to, you can review the recording on our YouTube channel and from org. And thank you all for being here. And don't forget, there's Deuxième Avis also, who is the sponsor. And see you soon next month at
Bye-bye.
USF.
Thank you.
Thank you.
Thank you all.
Bye-bye.
Au revoir.